do we need integrated care pathways as well, Dr. Bachert?
Oh, absolutely. I think the thing here is really to decide which or who of the patients really needs that treatment. Is the patient very likely to respond? Because we don't want to treat patients with difficult or with expensive medication, and at the end they don't have any profit from it. So we have to really install guidance on who is eligible, who would possibly be better for the one or the other monoclonal antibody. If that is the case, fine. If not, how we do further go on, maybe try a second one, whatever. But there's a whole algorithm of treatment that needs to be developed, also including surgery at a certain point. But of course, you cannot impose surgery on the patient. If the patient is not willing to undergo surgery, you cannot go further there. And for these patients, then they go sort of a step down to that kind of treatment if there is no other options. And that will have to be developed. So that's something we have to develop in the moment we have the results of the phase 3 study and understand who of these patients would really benefit from this treatment best.
Dr. Hopkins, to you, what's the importance of an integrated care pathway?
Well, I think one of the things that we need to do better is educate our colleagues in primary care to spot these patients early on. We've heard that late onset asthma patients that lose their sense of smell often languish in primary care for a long time before anyone picks up on the nasal polyps. So we need to improve entry into the integrated care pathway. And then, again, amongst our ENT colleagues, I allow them to identify the patients who aren't going to do well after a simple polypectomy or a limited FES procedure or a single dose of steroids, so that they get to academic centres early on in their pathway and have appropriate surgery and are considered eligible for these drugs at the right time. So it's streamlining the movement along the pathway, I think, will be critical.
We still have a need for more research. Yes?
Yeah, I would like to know if the integrated care pathways could, for example, for asthma patients, do something to improve adherence, because we see that many patients are non-manageable asthma patients only because it's difficult to be compliant. And then some of them go to biologics without being compliant to the standard of care treatment.
That's a very important point. So what we are doing for this patient, we are never prescribing rapidly this kind of medication. We are really trying to select patient to exclude. So when we see a patient with so-called severe asthma, we have to distinguish those who have difficult asthma, but not really a severe disease because of poor adherence or a poorly treated comorbid disease, either nasal disease or reflux, etc., poor environment, smoking, etc. So we have first to deal with these aspects to exclude that the patient has a difficult asthma, but can be controlled by improving adherence and other factors. And so this takes some time, at least I would say 4 to 6 months, before really being sure that the patient does have severe asthma. And at this stage, we can see whether the patient is eligible to this kind of therapy. So that's really a key, indeed, first step in our asthma clinic, is to identify those who are really having severe asthma versus those who have difficult asthma. That's probably the same kind of issues that might be present for the nose, I guess, from my ENT colleagues.
Mm-hmm.